making sure that the scavenging system's turned on, checking the breathing system for leaks, the manual and automatic ventilation system that's switching from bed to bed. Are your monitors on and in good working position? And then the final position of the machine in the room. Some facilities go as far as to put tape or marks on the floor where the anesthesia machine is supposed to sit. Should you ever have to move one, look for marks to put it back so that they don't yell at you about messing their rooms up. Are there any questions on anesthesia machines in general? Because we're going to go more into depth on the two distinct types of anesthesia machines that you're going to see in medical facilities in the next section. Any questions? Okay. Before you all get that glazed over look.
Is there like a specific machine for like children, like they would use here at Children's? Like, do they have a infant child anesthesia machine that
Well, actually, the anesthesia machines are manufactured that they can deliver as low as like 70 milliliters a minute.
Gotcha.
You know, the ventilation is adjusted way low, and the respiration rates are adjusted higher than what they are for adults.
Okay.
That's all it.
I didn't know if there was like a specific machine that works
better.
better.
Some of them do have a menu to where you select the size of the patient. Right. It'll say adult or pediatric. Okay. And it'll bring up that different menu, which is, you know, kind of all designed around the size of the patient. But it's a clinician's preference how they ventilate a patient. Okay. More and more we're going away from mechanical ventilation with going to spontaneous breathing modes of operations on machines, like pressure support, if you've heard that before. And we're getting away from using ET tubes in patients. They're going to laryngeal masks now, which can cause a lot of problems for biomed because they're going to tell you the machine's leaking.
And they don't have their mask on, right?
Well, they had it positioned correctly to begin with, and maybe they had to reposition the patient for something special, like they rolled the patient or sat him up, and just movement can unseat a laryngeal mask. And that's something that we cannot tell the clinician to do. We can't tell them how to practice. All we can do is that if we get a complaint on a machine like that, is to put it through its paces and make sure that it's functioning according to manufacturer specifications. But don't dare tell them how to practice. No. And you could say, oh, there could have been a leak anywhere in the disposables. That covers everything. Okay, the anesthesia provider. The clinician is the person responsible for the patient. It is his or her responsibility to manage the patient so the surgeon can perform corrections to the patient's condition. I like to refer to anesthesia as the mama of the OR. When mama ain't happy, ain't nobody happy. You piss off anesthesia, it's a bad day in surgery. They're the ones that they have the patient's life in their hands, and I'll tell you, it's a lot of art as well as science and a lot of practice, knowing how a patient's going to respond to certain drugs. The three goals of anesthetic agents are the effects: safe, reversible unconsciousness. And that's your amnesiacs, like propofol, Versed, Valium. This is to kind of shut the brain out of the pattern. Has anybody here undergone general anesthesia? They put you to sleep, you don't remember anything until they're waking you up. Goal one achieved, okay? But this is also why we have biz monitors, because everybody responds just a little bit different to the drugs. They put you out with the amnesiacs. They keep you under with the vaporized gas. They manage your pain with the narcotics, which is analgesia. And they manage movement because there is sometimes especially in thoracic surgery, involuntary movements where the brain is still getting signals from that, and muscles can jump and grab it. So they use paralytics to stop that movement. The anesthesia machine and monitor form what I like to call the flight deck of patient information. This allows the clinician to manage each patient from induction, which is the start of the case, to the time the patient regains consciousness. There are a lot of different parameters that they are looking at. Increasing blood pressure, increasing respiration, or increasing heart rate can indicate that the patient isn't under enough. And now we use biz monitors to make sure that the brain is effectively numb. What all anesthesia machines have in common: pneumatic chassis, that's your high pressure, intermediate pressure, and low pressure systems. Breathing system, this is what the patient is interfaced to. And it has the APL valve, the patient interface, a bag arm, and the rebreathing portion is where the soda line is. The third system would be the waste anesthesia gas disposal, which is also called the scavenger system. And not all anesthesia machines have ventilators. There are what they call field models for like military, oral surgery, veterinarian, which do not have ventilators. They use the bag to ventilate their patients. Common and generic terms. Pop-off. If you hear a clinician use this, it most commonly refers to the APL valve, airway pressure limiter. Soda line. There's a whole host of absorbents on the market. Common generic term for it is the soda line. Could be Sodazorb, could be Metazorb, Lozorb, Amzorb. Vaporizer. This is a drug delivery device that sits on the anesthesia machine that turns a liquid agent into a vapor delivered to the patient. Circuit refers to the disposable breathing tubing for the patient and the bag. And again, bag. I'm now going to burn. Breathing reservoir and a method of delivery to the patient. Okay, 3 types of anesthesia machines. Volume compensating, fresh gas decouple, and the portable machine. Volume compensating will always have an ascending bellows. Okay, that's your GE machine, Penlon, Mindray. And what it does is that it has software, external flow sensors and software that compensate for changes in the delivered volume to the patient. They become highly accurate nowadays, that they can, it doesn't matter what flow you dial in. It used to be with the volume compensating units that the higher the flow, the higher the tidal volume. Now it has algorithms in the ventilator that try to keep it at what you set it. Fresh gas decouple. These are your new Draeger machines, Fabius and Apollo. And they have a piston drive system and another system, the Datascope Anastar, which is kind of going by the wayside, had a descending bellows in it. The reason that it has a piston or a descending bellows is that there's valves that open and close according to the software in the vent that make it that the tidal volume is not tied to the flow going into the machine. These machines are highly accurate. There will be an internal flow sensor which sends out liters per minute to the breathing system, and then an external flow sensor, and they work together to make sure that the tidal volume delivered to the patient remains constant. And one of the distinguishing things about the fresh gas decoupled system is that their breathing system will be heated, and that will be to protect the flow sensor. It has nothing to do with, clinical applications to the patient. It's purely and simply to protect a hot wire flow sensor. In the Draeger, it's a little Venturi unit with crosshairs in it, and these two wires are heated. And it can tell by the flow going over it, the change in the temperature and the change in the resistance, what the tidal volume actually is. It's highly sensitive, highly sensitive. And then 3, there's the portable devices that I've mentioned, which you probably won't see in a medical center or a surgical center. These are more like oral surgeons and traveling anesthesias and veterinarian, military also. They were developed for the military. The vaporizer. This is an example of the GE Tech 7, which is what you see on most of GE machines. This is a funnel fill system. There can be key lock systems, funnel fill systems, and they're either kept in the anesthesia workroom to interface to the bottles or on the machines themselves, usually in the top drawer. And it's to prevent you from putting the wrong agent in the wrong vaporizer, although it can be done. This is a nice picture, shows the pathway of gas through the anesthesia machine. For the gas to get down to where the vapor is, the dial must be turned on. Otherwise, it's just passing it straight through the manifold. It doesn't, as soon as you turn it on, pins engage, which allow gas flow from the manifold up and through the vaporizer. The dial determines how much flow gets to the agent below to turn it to vapor. And the quickest way to ramp up the anesthesia agent in a circuit is to increase the flow and increase the dial setting. Okay, here we get into the nuts and bolts of this. Troubleshooting tips. Is it machine or monitor? A lot of times you're going to get complaints. This monitor is malfunctioning. It's not giving me accurate data. It might not be the monitor at all. In fact, a lot of times it's not. Clinicians like to point to the monitor first. Anybody taking a call with high inspired CO2? They're saying that the inspired CO2 on the monitor is not returning to 0.
Yeah, high end title. Yeah.
What you're gonna look for, first of all, is exhausted absorbent on the anesthesia machine. They should be changing this out regularly. There are